Welcome to the deep dive. Get ready to explore a system that's absolutely fundamental to how we interact with the world, often without us even thinking about it. The intricate and interconnected world of the ear, the nose, and the sinuses.
Yeah, it's quite a setup.
It really is a remarkable piece of biological engineering,
Yeah.
responsible for hearing, balance, breathing, and our sense of smell. So much going on there.
And for this deep dive, we're leveraging some really comprehensive source material. We've got excerpts here from a detailed surgical text, which lets us go beyond just the basics. We can really understand the intricate anatomy, the common conditions, and sort of the principles that guide how professionals diagnose and manage issues in these areas.
Exactly. So our mission today is to take this, wealth of information, unpack it layer by layer, and maybe distill the most important knowledge and insights.
Right.
We're aiming to give you that real aha moment, that understanding of what's happening under the hood. Basically, providing you with a shortcut to becoming genuinely well-informed about this complex part of the body.
Yeah, like the pros.
Just like the professionals who work with it every day.
It's about building a robust mental model, isn't it? Seeing how these parts fit together, why certain problems cause specific symptoms, and how that guides diagnosis and treatment. This source material we have is a fantastic roadmap for that.
Couldn't agree more. Ready to dive in and master the essentials of this incredible system.
Let's do it.
Okay, let's unpack this. And we'll start our journey with what many consider an evolutionary masterpiece. The ear.
The ear is indeed a marvel, really. And the best way to begin understanding it is to look at its basic structure, how it's organized into three main parts.
Okay.
We have the external ear, the middle ear, and the inner ear. What's really significant from a biological perspective is that these parts develop from different origins during embryonic growth.
Different origins? How so?
Well, the external and middle ear structures largely arise from the first two branchial arches. These are basically structures in the developing embryo that give rise to parts of the face, jaw, and neck.
Got it.
The inner ear, however, the parts actually responsible for hearing and balance, develops from neuroectoderm. That's the same tissue that gives rise to the brain and nervous system.
So they have fundamentally different blueprints from the very start, like completely separate origins.
Precisely. And this developmental difference is crucial when you're considering congenital issues, problems present at birth.
Okay.
You can have significant malformations of the external ear, like a poorly formed pinna or maybe a narrow ear canal, potentially associated with abnormalities of the middle ear structures.
Right.
But the inner ear might be perfectly normal. This means the potential for hearing is still there. The challenge is just getting the sound to the inner ear. This distinct origin explains why you can see those isolated external or middle ear issues.
That distinction makes a lot of sense. Okay, let's break down those three parts then, starting with the external ear. What are we looking at there?
So the external ear consists of the pinna, which is the visible part on the side of your head, often called the auricle, and the external auditory canal, or ear canal. That's the tube leading inwards. In adults, the ear canal is typically about, 3 centimeters long. Its structure isn't uniform either. The outer 2/3 is made of cartilage, while the inner 1/3 is bony.
And there's that fascinating, almost ingenious self-cleaning mechanism built into the ear canal, right? Something I think most people don't realize.
Absolutely. It's one of the coolest anatomical features, really. The skin lining, the external auditory canal, is unique.
How so?
Well, the skin on the lateral surface of the tympanic membrane, the eardrum, doesn't just shed in place like skin elsewhere on your body. Instead, it slowly migrates outwards along the ear canal walls.
Like a tiny conveyor belt.
Kind of, yeah. Exactly like that. This mechanism is designed to carry serum and earwax and any trapped debris naturally out of the canal.
Which explains why cotton buds are generally a bad idea. You're working against that natural flow, potentially pushing wax deeper in.
Exactly. You're messing with this system nature designed to keep it clean. Another important point about the external canal is its nerve supply. It's incredibly richly innervated.
Really?
Oh, yeah. Branches from multiple cranial nerves, parts of the trigeminal, CNV, facial, CNV7, glossopharyngeal, CNX, and vagus CNX nerves, plus some cervical nerves, C10-3. This dense network contributes to something we'll discuss later, referred pain.
Got it. And the skin here is also attached differently than skin elsewhere, right? Which affects how it feels when it's inflamed.
That's right. The skin in the bony part of the canal, especially near the eardrum, is very thin and tightly bound down to the underlying bone, or perichondrium, that membrane covering cartilage.
Okay.
Unlike skin on your arm, say, which can swell outwards when it's inflamed, The skin in the ear canal has pretty much nowhere to go.
Ah.
This lack of space means even minor swelling puts significant pressure on those abundant nerve endings, resulting in severe pain. That's characteristic of conditions like swimmer's ear or otitis externa.
Okay, moving past the eardrum then, we enter the middle ear. This air-filled chamber contains the body's smallest bones.
Correct. The middle ear is an air-filled space located within the temporal bone. Its boundary on the outside is the tympanic membrane, or eardrum. Inside this space reside the three tiny ossicles: the malleus hammer, incipit anvil, and stapes stirrup.
Tiny little things.
Incredibly small. Our source material has a great illustration showing these structures and how they're arranged. Sound waves cause the tympanic membrane to vibrate, and these vibrations are then mechanically transmitted and amplified through the linked chain of these three ossicles.
And they aren't just passively passing vibrations, they're doing something crucial to make hearing possible in the inner ear, right? They're not just rattling along.
Absolutely not. This is where the transformer function comes in. The articular chain acts as a lever system, and it concentrates the force of the relatively large vibrations hitting the eardrum onto the much smaller area of the stapes footplate, which sits in the oval window of the inner ear. Why is this necessary? Because the inner ear is filled with fluid, and it's much, much harder to move fluid than air.
Right, like trying to push water versus air.
Exactly. This mechanism provides impedance, matching its Dirac, efficiently transfers the sound energy from the air in the middle ear to the fluid in the inner ear. Without this transformer action, most of the sound would just bounce off at the fluid boundary, and we wouldn't be able to hear faint sounds very well at all. The source material shows this energy transfer quite nicely.
The middle ear cavity also has some important anatomical neighbors that are key to understanding how infections can spread, I gather.
Very much so. The source diagrams show these key relationships. Posteriorly, so towards the back, the middle ear space is connected to the mastoid Ehrlich cells.
That honeycomb bone behind the ear.
That's the one. It's a honeycomb-like structure within the mastoid bone. This connection is direct, which is why middle ear infections can easily track backwards and cause mastoiditis.
Ah.
Anteriorly, towards the front, the middle ear connects to the nasopharynx, the back of the nose, and throat via the eustachian tube.
That's the tube that pops.
That's it. It's crucial for equalizing pressure between the middle ear and the outside world, allowing the eardrum to vibrate freely. And significantly, the facial nerve, cranial nerve 7th, which controls facial expression, passes directly through the temporal bone in very close proximity to the middle ear.
So problems there could affect your face.
Absolutely. Problems in the middle ear, like a bad infection or certain tumors, can potentially affect this nerve and cause facial weakness or paralysis.
Wow. That proximity explains a lot about potential complications. Okay, now for the deepest part, embedded within the densest bone in the body, the otic capsule, the inner ear.
Right. The inner ear is a fluid-filled labyrinth where the really clever stuff happens, the conversion of mechanical energy into electrical signals that the brain can understand. This is for both hearing and balance.
Two jobs in one tiny space.
Exactly. It consists of two primary functional components: the cochlea, which is dedicated to hearing, and the vestibular labyrinth, which is responsible for our sense of balance and spatial orientation.
Let's unpack the cochlea first. It gets its name from the Greek word for snail shell because of its shape, right?
That's right. It's a spiral-shaped structure that makes about 2 3/4 turns. Inside, it's a marvel of microanatomy. The diagrams in our source show its internal layout pretty clearly. Running through the spiral is the cochlear duct, and this contains a unique fluid called endolymph.
Endolymph, what's special about it?
It's unusual because it has a high concentration of potassium ions, similar to the fluid inside cells normally. This duct is partitioned from the spaces above and below it by two thin membranes. Reisner's membrane separates it from the scala vestibuli above, and the basilar membrane separates it from the scala tympani below.
And those other spaces, the scalae.
The spaces above and below the cochlear duct, the scala vestibuli and scala tympani, are filled with perilymph.
Perilymph. And perilymph is different from endolymph.
Crucially different. Perilymph has a high concentration of sodium ions, much more like the fluid outside cells. And it's actually in communication with the cerebrospinal fluid, CSF, that surrounds the brain and spinal cord via a small canal.
So you have these two fluid systems, endolymph and perilymph, with very different chemical compositions, separated by delicate membranes. Why is maintaining those different ionic environments so critical?
This is absolutely fundamental to the inner ear's function. Seriously key. The difference in ion concentrations creates an electrical potential difference across the hair cells, the sensory receptors.
Like a tiny battery.
Sort of, yeah. Maintaining these ionic gradients requires active biological transport mechanisms and provides the electrochemical energy needed for the hair cells to convert mechanical vibrations into electrical nerve impulses. The paralymphatic space containing the scala vestibuli and scala tympani runs from the oval window where the stapes pushes around the cochlea to the round window membrane, which bulges outwards to accommodate the pressure changes. Our source shows how the stapes movement creates this pressure wave in the paralymph.
And those hair cells are the ultimate transducers of sound, right, doing the real conversion.
They are the sensory cells that do the magic. There are approximately 15,500 hair cells in total in each human cochlea, organized into one row of about 3,500 inner hair cells and 3 rows of about 12,000 outer hair cells.
Inner and outer, they do different things.
They do. When the pressure wave in the paralymph causes the basilar membrane to vibrate, it creates a shearing motion between the tops of the hair cells, specifically their hair-like projections called stereocilia, and an overlying structure called the tectorial membrane.
And that shearing motion is the key event.
Yes. This mechanical shearing force opens ion channels in the stereocilia, leading to a change in electrical potential within the hair cell they depolarize. The inner hair cells are the primary sensory receptors. They convert this mechanical stimulus into an electrical signal, which is then transmitted to the auditory nerve fibers.
Okay, so they send the message. What about the outer ones?
The outer hair cells are fascinating. They contain contractile proteins. While they also respond to the shearing motion, they don't directly transmit the main acoustic signal to the brain. Instead, they actually contract and expand.
They move.
They physically move. They act like biological amplifiers or tuners. This active motility sharpens the vibration of the basilar membrane, making the inner hair cells exquisitely sensitive and allowing them to respond very precisely to specific frequencies of sound. Each inner hair cell along the basilar membrane is optimally tuned to respond to a particular sound frequency, creating a frequency map that the brain interprets as different pitches.
It's an incredibly detailed and delicate system just for hearing.
Wow.
Now what about balance, the vestibular labyrinth?
The vestibular labyrinth, located right next to the cochlea, works on a similar principle, using hair cells, but responds to gravity and head movements instead of sound vibrations. It consists of 2 main sets of structures, the 3 semicircular canals and the 2 otolith organs, the utricle and the saccule.
The semicircular canals seem designed to detect rotation, like spinning around.
Exactly. There are 3 semicircular canals, superior, posterior, and lateral, and they're oriented roughly at right angles to each other in 3 different planes.
Covering all angles.
Precisely. This allows them to sense angular acceleration, or rotational movements of the head. Within a swelling at the base of each canal, hair cells are embedded in a gelatinous structure called the cupula. When you rotate your head, the fluid, endolymph, inside the canal lags behind the movement of the canal walls due to inertia.
Ah, inertia.
Right. This relative movement of fluid causes the cupula to be deflected, bending the hair cell's stereocilia and generating nerve impulses that signal the brain about the direction and speed of head rotation.
And the utricle and saccule, what do they do?
The utricle and saccule are the otolith organs. Otolith means ear stone.
Ear stones, really.
Literally. Within these organs, hair cells are embedded in a gelatinous membrane called the otoconial membrane, which contains tiny calcium carbonate crystals called otoliths. These crystals provide mass, making the membrane heavy and sensitive to gravity and linear acceleration movement in a straight line.
So like speeding up in a car or going up in an elevator.
Exactly that. The utricle is primarily oriented to sense horizontal linear movements and head tilt, while the saccule is oriented to sense vertical linear movements and gravity. As your head tilts or accelerates, gravity or inertial forces cause the otoconial membrane to shift, bending the hair cells beneath it and sending signals about the head's position and linear motion.
So the semicircular canals handle turns, and the utricle saccule handles straight line motion and gravity. All that information goes to the brain via the vestibular nerve. Makes sense.
Correct. Impulses from the hair cells in both the semicircular canals and the otolith organs travel along the vestibular nerve, which joins the cochlear nerve to form the 8th cranial nerve, CN8, the vestibulocochlear nerve. These signals are processed in the brainstem and sent to various central areas. Connections to the spinal cord help maintain balance and posture. Connections to the cerebellum aid coordination, and crucial connections to the eye muscles allow for the vestibulo-ocular reflex.
The what reflex?
The vestibulo-ocular reflex. That's what stabilizes your gaze on a target, even when your head is moving. So you can say, read a sign while walking.
Oh, okay.
This entire system is constantly providing the brain with a real-time map of your head's position and movement in space.
It's incredible how seamlessly the brain integrates these signals from both sides to keep us upright and oriented. Let's go back to the point you made earlier about the rich nerve supply to the ear and referred pain. That sounded important.
This is a really important clinical concept, yeah.
Yeah.
As we mentioned, the external and middle ear receive sensory innervation from a surprisingly wide array of nerves. Branches of the trigeminal, CNV, facial, CND7, glossopharyngeal, CNAX, vagus, CNX, and upper cervical nerves, C23.
Wow, that's a lot of nerves converging there.
It is. And because these same nerves also supply other areas, the teeth, tongue, throat, larynx, etc., irritation or pathology in one of these other locations can be perceived as pain in the ear, even though the ear itself is perfectly healthy. This is known as referred otalgia.
Referred ear pain.
Okay.
And the source highlights a particularly critical example of this.
Yes, it does. One of the most significant examples of referred otalgia is pain in the ear caused by malignancy, by cancer, in the hypopharynx or larynx, the lower parts of the throat, and the voice box. Because these areas share innervation with the ear, particularly via cranial nerves, TIX, glossopharyngeal, and X vagus, a seemingly innocent earache, especially if it's unilateral, persistent, and there are no findings in the ear itself. That earache could be the only presenting symptom of a serious cancer elsewhere in the head and neck.
That's sobering. It really underscores why a thorough examination beyond just the ear is essential for persistent ear pain.
Absolutely. You can't just look in the ear and call it a day if the pain persists without an obvious ear cause.
That's a powerful point that changes how you think about a simple earache, which leads us naturally into how clinicians examine the ear.
And the source makes it crystal clear. The single most important part of the assessment for any ear complaint is taking a thorough history.
The story matters most.
It really does. You need to ask specific questions about the symptoms the patient is experiencing, guided by a structured approach like the points listed in our source material, like in Table 51.1. Things like the nature, severity, and duration of pain or itch, the onset, type, and amount of any hearing loss, the presence and characteristics of discharge, color, consistency, smell, whether they experience ringing or buzzing sounds, tinnitus, spinning sensations, vertigo, any facial weakness.
Right.
And importantly for children, their speech development and overall developmental milestones, as hearing loss can impact these significantly. You also need to inquire about past history that could be relevant. Head injuries, exposure to loud noise or pressure changes, barotrauma, previous ear infections or surgeries, exposure to medications that can damage the ear, ototoxic drugs, and any family history of hearing problems.
You're essentially doing detective work before you even pick up an instrument.
Precisely. Building that clinical picture is paramount. For the physical examination of the ear, the primary tool is the otoscope. Nowadays, this is typically a fiber optic otoscope, often with a pneumatic attachment.
Pneumatic, like air.
Yeah, it allows you to puff a little air into the ear canal to see how the eardrum moves, which gives clues about middle ear pressure and fluid. You'll also need a selection of speculum, the tips that go into the ear canal. A 512 Hz tuning fork is a standard tool for basic hearing screening tests at the bedside.
And there's a specific, safe way to hold the otoscope, isn't there? I remember learning that.
Yes, crucial for patient safety. The source material illustrates this well. You need to gently pull the pinna upwards and backwards in adults, downwards and backwards in young children, to straighten the natural curve of the ear canal.
Okay.
And vital to prevent accidentally injuring the eardrum if the patient moves, you should balance the hand holding the otoscope by resting your little finger or the side of your hand on the patient's cheek or head.
Ah, makes sense.
This ensures that if they suddenly flinch, your hand moves with them, and the speculum doesn't get jammed into the eardrum. As part of a general ENT exam, you'd also typically examine the nose, throat, and neck, and specifically for ear complaints, a neurological assessment, paying close attention to the function of the cranial nerves, particularly the facial nerve given its proximity.
For hearing assessment, beyond just talking to the patient, there are more formal tests.
While asking about hearing and conversational testing gives you a rough idea, the gold standard for precisely measuring hearing thresholds is pure tone audiometry.
The test in the soundproof booth?
That's the one. It's performed in a soundproof booth, testing hearing sensitivity at different frequencies for both air conduction, sound traveling through the ear canal, eardrum, and ossicles, and bone conduction.
A bone conduction.
Yeah, that's sound bypassing the external middle ear and directly stimulating the inner ear through vibrations applied to the skull. Our source shows how this works. This testing allows you to determine if a hearing loss is conductive, problem in the external middle ear, sensorineural, problem in the inner ear or nerve, or mixed.
And the tuning fork tests like Rinn and Weber, are they still used?
They are. They're quick, simple tests to help distinguish between conductive and sensorineural loss at the bedside, though they don't give precise measurements like the audiogram. The source also lists a range of other audiological tests used for more specific questions. Speech audiometry tests how well you understand spoken words. Tympanometry and stapedial reflex testing assess middle ear function, pressure, and eardrum mobility. And objective tests like auditory brainstem response, ABR, and otoacoustic emissions, OAEs, are crucial for testing hearing in infants or those who cannot participate in behavioral tests. Vestibular function can be assessed with caloric testing or electronystagmography, ENG.
Okay. Moving beyond the physical exam, imaging plays a role in certain ear conditions. CT scans.
Absolutely. Computed tomography, or CT scanning, is the primary imaging modality for evaluating the bony structures of the temporal bone. It provides detailed cross-sectional images that are invaluable for assessing anatomy before surgery, looking for bone erosion, evaluating the mastoid air cells, and identifying problems like cholesteatoma.
Cholesteatoma. We'll get to that.
We will.
Okay.
CT shows it as a soft tissue mass. The source has a great figure comparing a normal air-filled middle ear and mastoid versus one that's completely opaque with soft tissue, potentially indicating significant disease like cholesteatoma or fluid. CT shows bone, air, and dense material like pus or cholesteatoma matrix very well.
And MRI offers a different view. Complementary, perhaps.
Exactly. Magnetic resonance imaging, or MRI, is superior for visualizing soft tissues and neural structures. It's the imaging modality of choice for evaluating the cranial nerves associated with the ear, particularly the facial nerve and the vestibulocochlear nerve, CNDA.
So better for nerves.
Much better. It is considered the best method for diagnosing acoustic neuromas, also called vestibular schwannomas, which are tumors arising from CN8. Our source actually shows one clearly on an MRI. A specific type of MRI sequence, diffusion-weighted MRI, is particularly sensitive for detecting recurrent cholesteatoma, which can otherwise be difficult to distinguish from scar tissue on standard imaging after surgery.
Okay, with the foundation of anatomy and diagnosis set, let's delve into some specific conditions, starting with the external ear again. Congenital anomalies.
Right. Going back to development, congenital anomalies of the external and middle ear often occur together due to their shared branchial arch origin. These range from minor deformities of the pinna to complete absence of the ear canal, atresia, and vesicular malformations.
And the key point again.
Critically, as the inner ear develops separately, the cochlea and auditory nerve can be perfectly normal. This means these children often have hearing potential that can be accessed with surgery or hearing aids. The incidence is around 1 in 10,000 to 1 in 20,000 births.
Trauma to the external ear is quite common too, I imagine. Bumps and scrapes.
It is. A classic example is a pinna hematoma, a collection of blood under the perichondrium, that fibrous tissue covering the cartilage of the pinna.
How does that happen?
Usually results from blunt trauma, like a blow during contact sports, think rugby players. If this blood clot isn't promptly and effectively drained, the perichondrium can separate from the cartilage, disrupting the blood supply to the cartilage.
And that's bad for cartilage.
Very bad.
Yeah.
The cartilage can then die, necrosis, leading to scarring, fibrosis, and the characteristic permanent deformity known as cauliflower ear. The source shows a hematoma.
Ouch. How's it treated?
Treatment involves urgent surgical incision, drainage, and then a pressure dressing or through-and-through sutures to reattach the perichondrium to the cartilage and prevent the blood from recollecting. Prophylactic antibiotics are given to prevent infection.
And foreign bodies in the ear canal, especially with kids sticking things in there.
Very common, particularly in young children. The source stresses that the easiest and safest removal is usually the first attempt by an experienced clinician, ideally using a microscope to visualize the foreign body and the delicate ear canal walls.
Better visualization helps avoid damage.
Exactly. For young or uncooperative children, or those with learning difficulties, general anesthesia may be necessary to ensure safe removal without damaging the ear canal or eardrum. And a critical point, if the foreign body is a button battery,
Oh dear.
it must be removed within the hour. Button batteries can cause rapid and severe damage through electrical discharge and corrosive effects if they become lodged in the ear canal. Really serious.
Good to know. Okay, infections of the external ear, like otitis externa or swimmer's ear, also widespread.
Otitis externa is a very common inflammation or infection of the skin lining the external auditory canal. It's often triggered by factors that disrupt the skin's natural barrier or trap moisture. Trauma from things like cotton buds or scratching, exposure to water, swimmer's ear, underlying skin conditions like eczema, or factors that compromise the immune system like diabetes.
What are the usual culprits?
Bacteria.
The most common bacterial pathogens are Pseudomonas aeruginosa and Staphylococcus aureus. Fungi, particularly Candida and Aspergillus, can also cause otitis externa, especially after antibiotic use has killed off the normal bacteria.
Okay.
The inflammation and swelling prevent that normal outward migration of skin we discussed earlier.
Right, the conveyor belt stops.
Exactly. This leads to a buildup of infected debris, which further feeds the infection.
And the key symptom differentiating it from a middle ear infection. You mentioned the pain earlier. The hallmark symptom of otitis externa is pain that is made worse by manipulating the pinna or pressing on the tragus, that small cartilage flap in front of the ear canal. This exquisite tenderness is usually absent in uncomplicated middle ear infections.
Got it. Treatment.
Initial treatment involves topical antibiotic and corticosteroid ear drops to target the infection and reduce inflammation, along with pain relief. If the infection doesn't improve, thorough cleaning of the ear canal under microscopic visualization to remove infected debris is essential. Topical drops just can't reach the skin effectively, through pus and sloughed skin otherwise.
You mentioned fungal infections. How do you spot those? Are they different?
Fungal otitis externa, or automycosis, is often intensely itchy and can present with a fluffy-looking discharge or visible fungal hyphae threads or spores in the ear canal on examination. The source has a picture of this fungal debris. Treatment involves meticulous cleaning to remove the fungus, using topical antifungal drops, and crucially, stopping any concurrent antibiotic drops that might be encouraging the fungal growth. Systemic antibiotics are generally not needed for routine otitis externa unless the infection has spread beyond the ear canal skin, causing cellulitis of the pinna. The source shows an example of an inflamed, swollen pinna from cellulitis.
There's a much more severe, even life-threatening form of external ear infection, though, right? Necrotizing otitis externa.
That's necrotizing otitis externa, yes. Sometimes called malignant otitis externa, though it's not cancer. This is a rare but serious infection, most commonly seen in elderly individuals with diabetes or other immunocompromising conditions. It's a progressive infection that starts in the ear canal, but invades the surrounding bone of the skull base, leading to osteomyelitis.
Infection in the skull bone. That sounds bad.
It is. It presents with severe, unremitting, often excruciating ear pain, typically unilateral, that doesn't respond to standard treatment, sometimes accompanied by facial nerve weakness. The causative organism is almost always Pseudomonas aeruginosa.
And the risk here is spread.
Yes, the infection can track along the skull base, potentially affecting multiple cranial nerves, 7 like second nerves, 12, and spreading intracranially. It requires prompt diagnosis, hospitalization, aggressive, long-term intravenous antibiotic therapy, and often a multidisciplinary team approach involving ENT surgeons, infectious disease specialists, and radiologists. It's a true medical emergency.
Okay, let's talk about growths in the external ear. Are they common?
Most growths in the external ear are benign. Exocysts are very common. They aren't true neoplasms, but bony outgrowths in the deep, bony part of the ear canal.
What causes them?
They are strongly associated with prolonged exposure to cold water, hence the term surfer's ear. Our source shows ear canals narrowed by these bony bumps. They only require treatment if they become large enough to obstruct the canal, trap water or debris, and cause recurrent infections or hearing loss.
Okay, what else?
Osteomas are true benign bone tumors, typically solitary and located more laterally than exostos is. Other rare benign tumors like papillomas and adenomas can also occur.
What about malignant tumors? Cancer.
Primary malignant tumors of the external ear are uncommon, usually rising from the skin. The most frequent types are basal cell carcinoma and squamous cell carcinoma. The source shows an example of an SCC. They often appear as non-healing ulcers or crusting lesions that grow slowly and can unfortunately be neglected by patients for some time.
Can they spread?
Squamous cell carcinomas can metastasize to regional lymph nodes, commonly in the parotid gland or neck. It's also important to consider invasion from nearby cancers, such as those originating in the parotid gland or the nasopharynx, the latter sometimes spreading via the eustachian tube. Treatment for resectable malignant tumors is primarily surgical excision, often combined with radiotherapy depending on the stage and type.
Okay, that's the external ear covered pretty thoroughly. Moving inwards again, let's look at conditions affecting the middle ear.
Right. Congenital anomalies of the middle ear, as mentioned earlier, can occur in isolation or as part of syndromes involving the first and second branchial arches, like Pierre-Robin sequence, Down syndrome, or Treacher-Collins syndrome. The incidence is around 1 to 2 per 10,000 births. They often present as unilateral hearing loss in a child with a visible external ear anomaly.
Trauma often affects the eardrum in the middle ear, a burst eardrum.
Yes, a perforated tympanic membrane is a frequent result of trauma. This could be a direct injury like poking something into the ear, a sudden pressure change like a slap to the ear or an explosion, or barotrauma from flying or diving. The source shows a traumatic perforation.
Does it heal?
The good news is that the majority of traumatic perforations, around 90%, will heal spontaneously within about 6 weeks. Our source actually shows one that has healed. Exceptions include larger perforations or those caused by severe blast or welding injuries. More significant trauma to the temporal bone can also disrupt the ossicular chain, most commonly displacing or fracturing the incus.
And if they don't heal or the bones are broken?
Both persistent eardrum perforations and ossicular discontinuity can be surgically repaired, a tamponoplasty for the perforation, and ossiculoplasty for the ossicular chain reconstruction.
Now let's talk about acute otitis media, or AOM, probably the most common ear condition people are familiar with, especially parents.
AOM is indeed one of the most frequent childhood illnesses. It has a peak incidence between 6 and 18 months of age, coinciding with the time children's immune systems are developing, and they are frequently exposed to viral infections.
Seems like every kid gets it.
Pretty much. By age 2, about 70% of children have had at least one episode, and by age 6, about 90%. AOM is characterized by the presence of pus, or purulent fluid, in the middle ear space, accompanied by signs and symptoms of acute infection.
What are those classic signs and symptoms? What should parents look for?
The key finding on otoscopic examination is a bulging, often red or opaque, tympanic membrane, indicating pressure behind it from the pus. The source has a picture of this classic bulging drum. Symptoms include ear pain, otalgia, fever, irritability, and lethargy.
And it usually follows a cold.
Often, yes. The typical organisms causing bacterial superinfection after a viral upper respiratory tract infection are Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis.
And the debate around antibiotics for AOM, are they always needed?
That's a good question. For uncomplicated AOM, initial management focuses on pain relief, using analgesics like paracetamol or ibuprofen, and managing fever with antipyretics. Many cases, particularly in older children, will resolve spontaneously with just supportive care. Systemic antibiotics are typically considered for children under 2 years old with bilateral AOM, or for children of any age with severe symptoms or other risk factors for complications.
But there can be complications from AOM, right? It's not always simple.
Yes, although less common than in the past with antibiotics, complications still occur. The most frequent is mastoiditis.
We mentioned that connection earlier.
Exactly. Infection spreads from the middle ear into the mastoid air cells. Mastoiditis requires hospital admission for intravenous antibiotics. It's crucial to monitor closely for more serious, albeit rarer, complications because of the mastoid's proximity to vital structures.
Like what?
These include facial nerve palsy, as the nerve runs through the mastoid, lateral sinus thrombosis, a blood clot in a large vein in the skull, or intracranial spread leading to meningitis or brain abscess.
Serious stuff.
Very. If the infection doesn't respond rapidly to IV antibiotics, surgical intervention like aspirating a superior steel abscess, pus collected under the membrane covering the bone, or performing a myorrhizotomy might be necessary.
A myorrhizotomy.
That's a small incision in the eardrum, sometimes with insertion of a ventilation tube or grommet to drain the middle ear. A cortical mastoidectomy, surgically removing infected mastoid bone, is performed in cases of complicated mastoiditis or failure of medical therapy. The risk of infection spreading to the cranial cavity from severe, untreated, or poorly managed AOM or mastoiditis is a constant consideration.
Okay. Another very common issue, especially in early childhood, is otitis media with effusion, often called glue ear. How is that different from AOM?
OME is distinct from AOM in that it's characterized by the presence of fluid in the middle ear space without signs or symptoms of acute infection. The fluid is often thick and sticky, like glue, hence the common name.
So no active infection, just fluid.
Right. It is a bimodal incidence pattern, peaking around age 2, when children start nursery, and again around age 5, when they start school, suggesting a link to increased exposure to viral infections and immature eustachian tube function. It's also more prevalent during the winter months.
What causes that fluid buildup if there's no active infection? Why does it happen?
The underlying issue is usually dysfunction of the eustachian tube. In young children, the tube is shorter, more horizontal, and its cartilage is less rigid than in adults, making it more prone to blockage or poor function, often after a viral cold.
Okay.
This leads to inadequate ventilation of the middle ear. As the air in the middle ear is absorbed, it creates negative pressure.
A vacuum effect.
Kinda, yeah. Which in turn causes fluid to transudate, essentially, leak out from the blood vessels in the middle ear, lining into the middle ear space. This fluid then thickens over time, becoming like glue.
And what are the consequences of having that fluid in the middle ear? What does it do?
The most significant consequence is hearing impairment. The fluid dampens the vibration of the eardrum and ossicles, causing a conductive hearing loss.
So, difficulty hearing.
Yes, and this loss is often fluctuating, worsening when the child has a cold. Persistent hearing loss during critical periods of language development can lead to delayed speech and language development, behavioral problems due to difficulty hearing instructions or participating, and potential difficulties with reading and learning at school.
That makes sense.
Furthermore, that static pool of fluid in the middle ear is an ideal breeding ground for bacteria, making children with OME more susceptible to recurrent episodes of acute otitis media.
So one can lead to the other. What do you see when looking in the ear with OME?
On otoscopic examination, the eardrum often looks dull, less transparent than normal, and may be retracted inwards due to the negative pressure. The source shows this dull appearance and sometimes visible radial blood vessels on the eardrum. A key diagnostic finding is that the eardrum is immobile when you use pneumatic otoscopy. You can't make it move by puffing air into the canal because of the fluid behind it.
Okay. How is OME managed then? Watchful waiting.
For children with bilateral OME and associated hearing loss, the initial approach is typically watchful waiting for about 12 weeks. About 50% of cases resolve spontaneously during this period as the child grows and their eustachian tube function matures.
And if it doesn't resolve?
Well, medical treatments like decongestants, antihistamines, or steroids have shown limited consistent benefit. Physical methods aimed at improving eustachian tube function can be tried, especially in compliant older children. This includes teaching them Valsalva maneuvers.
Trying to pop your ears.
Yeah, gently trying to pop their ears by blowing with pinched nostrils and closed mouth, or using devices like the otoventi. The source shows this. It involves inflating a balloon through the nose to pressurize the nasopharynx and potentially open the eustachian tube.
Interesting device. And if it persists despite all that?
If significant bilateral conductive hearing loss persists after the watchful waiting period and is impacting development, surgical intervention is considered. The most common procedure is the insertion of ventilation tubes, or grommets.
Grommets. Tiny tubes.
Exactly, inserted through a small incision in the eardrum. Myrigotomy. Grommets are tiny tubes that create a direct opening between the middle ear and the external environment, bypassing the dysfunctional eustachian tube and immediately restoring middle ear aeration and hearing. Adondectomy, the removal of the adenoids, may also be performed as enlarged or infected adenoids can contribute to eustachian tube obstruction.
Is OME only a problem for kids? Can adults get glue ear?
While overwhelmingly a childhood condition, adults can develop middle ear effusion, often following a severe cold or allergic reaction. However, and this is crucial, a persistent unilateral middle ear effusion in an adult is a critical warning sign that requires careful investigation.
Why unilateral specifically?
Because the eustachian tube connects the middle ear to the nasopharynx, unilateral OME in an adult could be caused by something blocking the nasopharyngeal opening of the eustachian tube on that side. The most concerning possibility is an obstructive tumor in the postnasal space, such as a nasopharyngeal carcinoma.
Okay, that's serious.
It is, and it's particularly relevant in certain populations like men from southern China. So persistent unilateral OME in an adult should never be ignored. A nasendoscopy, examining the nasopharynx with an endoscope, is usually mandatory.
That's a really important differential diagnosis to keep in mind. Okay, let's move to chronic otitis media, or COM-COM. How is that defined?
COM refers to a persistent abnormality of the tympanic membrane or middle ear, typically lasting for more than 2-3 months. It often results from long-standing OME or recurrent acute infections that have led to lasting damage. COM is classified based on whether it's active with discharge and inflammation or inactive, a dry perforation, and crucially into mucosal or squamous types. The source gives a classification framework.
What defines mucosal COM?
Active mucosal COM involves a persistent perforation of the eardrum with ongoing or recurrent ear discharge, otorrhea, from the inflamed middle ear lining, sometimes with granulation tissue that's inflamed fleshy tissue in the middle ear space. Inactive mucosal calm is simply a dry perforation of the eardrum without active infection.
Can you fix a perforation?
Yes. For perforations, surgical repair via tympanoplasty is often indicated, particularly for recurrent infections, as the discharge can damage the inner ear structures over time, and to potentially improve hearing. The source mentions a common goal, sometimes called the Belfast rule of thumb, to aim for the operated ear's hearing level to be 30 dBs or better, or within 15 dBs of the other ear.
And squamous calm. This is the one associated with cholesteatoma, right?
Yes, active squamous calm refers to acquired cholesteatoma. This is a serious condition accounting for about a quarter of active calm cases, with an incidence around 1 in 10,000. It presents typically with persistent, often foul-smelling, ear discharge that doesn't respond to drops, and progressive hearing loss.
So, what exactly is acholesteatoma? It's not cancer, you said.
Correct. It's not cancerous, but it's an abnormal ingrowth of keratinizing squamous epithelium, essentially. Skin into the middle ear or mastoid space where it doesn't belong.
Why is that skin where it shouldn't be so problematic? What does it do?
Because this trapped skin sheds keratin debris, which accumulates and expands. The cholesteatoma also releases S-linked enzymes and inflammatory mediators that actively erode and destroy the surrounding bone and tissues. It behaves like a locally destructive tumor, even though it's benign.
Wow, so it eats away at things.
It does. It can erode the ossicles, causing hearing loss. The bone covering the facial nerve, causing paralysis. The semicircular canals, causing dizziness. Or erode upwards or backwards into the skull.
Leading to those same serious complications as AOM.
Exactly. Potentially life-threatening intracranial complications like meningitis, brain abscess. The source notes a lifetime risk of 1 in 200 for a 30-year-old with untreated cholesteatoma or lateral sinus thrombosis.
So this requires intervention. You can't just leave it.
Absolutely not. Cholesteatoma will continue to grow and cause destruction if left untreated. The recommended treatment is always surgical. Mastoid surgery to access the middle ear and mastoid air cells and meticulously remove the entire cholesteatoma matrix and its contents. This is typically done with the aid of a surgical drill and often guided by a microscope or endoscope for precise removal. Reconstruction of the ossicular chain to restore hearing, ossiculoplasty, is often performed at the same time or as a second procedure.
Okay. Another condition leading to hearing loss in the middle ear is otosclerosis. What's that?
Otosclerosis is a genetic condition with an autosomal dominant inheritance pattern, meaning it can run in families, although its penetrance is variable. Not everyone who inherits the gene will develop the condition.
And what happens in the ear?
The pathology involves abnormal remodeling and overgrowth of bone in the temporal bone, specifically around the stapes footplate, where it connects to the oval window. The source shows this bony fixation. This extra bone restricts the movement of the stapes, impeding the transfer of sound energy into the inner ear.
And the result is a specific type of hearing loss, like the conductive type.
Exactly. It causes a progressive conductive hearing loss. It's typically suspected in younger adults, often starting in their 20s or 30s, who develop a conductive hearing loss on audiometry, but whose eardrum appears completely normal on otoscopic examination.
So the outer and middle ear look fine, but the sound isn't getting through properly. What are the treatment options?
Management options range from simply monitoring with reassurance that the hearing loss is mild, to fitting a conventional hearing aid to amplify sound. Surgical treatment is also highly effective. Stapedotomy.
Stapedotomy.
Yeah. In this procedure, the surgeon makes a small opening in the fixed stapes footplate and inserts a tiny prosthetic piston, usually made of Teflon or titanium, that connects to the incus. It effectively bypasses the fixed stapes and restores sound transmission to the inner ear. The source shows a diagram of this. Bone conduction hearing aids can also be an option, especially if surgery is not suitable or successful.
Are tumors in the middle ear common?
Tumors of the middle ear are rare. The most common one is a glomus tumor. The source shows a typical appearance behind the eardrum. These are paragangliomas, highly vascular tumors arising from specialized non-chromephin tissue, similar to carotid body tumors.
Glomus tumor. How are they classified?
In the temporal bone, they are classified based on their origin. Glomus tympanicum arising within the middle ear cavity itself, and glomus jugulare arising from the jugular bulb just beneath the middle ear.
What are the symptoms of a glomus tumor? How would you know?
Because they are highly vascular, a classic symptom is pulse synchronous tinnitus, a pulsatile ringing or whooshing sound in the ear that beats in time with the patient's pulse.
Hearing your own heartbeat in your ear.
Essentially, yes. They can cause conductive or mixed hearing loss.
Yeah.
As they grow, they can erode bone and affect nearby cranial nerves, potentially causing palsies of the facial nerve or lower cranial nerves,
Yeah.
9xx, 8, 11, 12, leading to difficulties with facial movement, swallowing, or voice. On examination, the classic sign is seeing a reddish or purplish mass pulsating behind the eardrum.
Treatment.
Treatment often involves preoperative embolization by interventional radiologists to reduce blood flow, followed by surgical excision. Radiotherapy is also an effective treatment option, especially for larger or surgically challenging tumors.
And are there malignant tumors in the middle ear? Actual cancer?
Yes, though much less common than glomus tumors, squamous cell carcinoma can arise in the middle ear. This happens particularly in the setting of chronic otitis media and chronic discharge, which can lead to inflammatory changes that predispose to malignancy over time.
How does that present?
It typically presents with deep, persistent ear pain that is often disproportionate to the appearance of the ear, blood-stained ear discharge, and often facial paralysis due to invasion of the facial nerve canal. Treatment is aggressive, radical surgical excision, often combined with radiotherapy, offering the best chance of cure, though it's a major procedure with significant potential morbidity.
That completes our deep dive into the middle ear. Now let's move on to the inner ear and conditions affecting hearing and balance at that deepest level. Congenital hearing loss first.
Right, congenital sensorineural hearing loss, SNHL, hearing loss present at birth, originating in the inner ear or auditory nerve. Causes are roughly equally divided between genetic and acquired factors.
Genetic causes.
Of the genetic causes, about 75% are non-syndromic, meaning hearing loss is the only major finding. The most common cause here is mutations in the connexin 26 gene. The other 25% are part of recognized genetic syndromes affecting multiple systems. The source lists several examples like Usher syndrome, hearing and vision loss, Pendred syndrome, hearing loss and thyroid issues, Jervell and Lange-Nielsen syndrome, hearing loss and heart rhythm problems, Wartenberg syndrome, hearing loss and pigmentation abnormalities, and others like Treacher-Collins, Alport, Stickler, neurofibromatosis type 2, NF2, and branchio-otorenal syndrome. Quite a list.
Wow. And acquired causes from events around birth, things that happen to the baby.
Acquired causes before or around birth include intrauterine infections like rubella, toxoplasmosis, or cytomegalovirus, CMV. Perinatal factors such as severe hypoxia, lack of oxygen during birth, severe jaundice or prematurity, and postnatal infections like bacterial meningitis, which can severely damage the cochlea.
The emphasis now is on early detection and intervention for childhood hearing loss, right? Screening is key.
Absolutely critical. Early identification and intervention are paramount for maximizing a child's language development and communication skills due to the brain's plasticity in the early years. In the UK, for example, all newborn babies undergo hearing screening, typically using otoacoustic emissions, OAEs.
OAEs.
Yeah, they're objective tests that measure faint sounds produced by the cochlea in response to stimuli. Quick and non-invasive. Babies who don't pass this screen are referred for more in-depth objective testing, like auditory brainstem response, ABR. The source shows an ABR set up to accurately determine their hearing thresholds at different frequencies.
And based on the results, what's the intervention? What happens next?
If there's residual hearing, fitting conventional hearing aids as early as possible is vital. For children with profound SNHL who gain limited or no benefit from hearing aids, cochlear implantation is often the recommended intervention.
Cochlear implants, how do they work?
A cochlear implant is an electronic device that bypasses the damaged hair cells and directly stimulates the auditory nerve fibers in the cochlea with electrical impulses. The source shows a diagram of an implant. This works because in most cases of SNHL, even when the hair cells are destroyed, the auditory neurons are still largely intact. Early implantation is crucial for the development of the auditory cortex in the brain.
Okay. Moving to the most common type of hearing loss overall, particularly as we age, presbycusis, age-related hearing loss.
Presbycusis is the gradual age-related decline in hearing. It's typically a bilateral, symmetrical sensorineural hearing loss, although one ear might be slightly worse than the other. It often begins subtly in middle age and becomes more noticeable later in life. It's frequently accompanied by tinnitus.
And it affects certain sounds more than others.
Yes, the hearing loss characteristically affects the higher frequencies first and most severely. The source shows a typical audiogram shape for this.
And that high frequency loss is particularly problematic for understanding speech, right? It's not just that things sound quieter.
Right. Exactly. While lower frequencies carry the power or volume of speech, many of the consonant sounds that help us distinguish words if, ik, me are high frequency. With presbycusis, people can often hear that someone is speaking. Lower frequencies are relatively preserved, but they struggle to understand what is being said because the high-frequency consonants are indistinct or inaudible.
Makes sense. 50 sounds like 60 maybe.
Things like that, yeah. This makes conversation difficult, especially in background noise, leading to frustration and social isolation.
How is presbycusis managed? What can be done?
Management primarily involves reassurance that it's a normal part of aging and doesn't mean total deafness is inevitable. The mainstay of management is fitting appropriately programmed hearing aids. Modern digital hearing aids are highly sophisticated and can significantly improve speech understanding and quality of life. The source shows a modern aid. Counseling on communication strategies is also important.
You mentioned tinnitus again, that ringing or buzzing sound.
Tinnitus is the perception of sound in the absence of an external source. It's an extremely common symptom, with about 30% of people experiencing it at some point in their lives. It can be perceived as ringing, buzzing, hissing, clicking, or other sounds.
What causes it?
While sometimes caused by specific conditions like those glomus tumors we talked about, pulsal tinnitus, in the vast majority of cases, it's subjective tinnitus associated with problems anywhere in the auditory pathway, but most commonly accompanying sensorineural hearing loss, including presbycusis, noise-induced hearing loss, or sudden SNHL.
Is there a cure for subjective tinnitus? Can you make it stop?
Currently, there's no simple cure for most subjective tinnitus. However, for most people, the brain learns to filter it out over time.
Yeah.
This is called habituation.
So you get used to it.
Often, yes. When it's intrusive, management focuses on reducing its impact. This includes reassurance and education about the benign nature of most tinnitus, sound therapy, like using masking sounds or white noise generators, to make the tinnitus less noticeable, and using hearing aids, if there's associated hearing loss, as amplifying external sounds can help mask the tinnitus. Cognitive behavioral therapy, CBT, and tinnitus retraining therapy, TRT, can also be helpful for managing the distress associated with intrusive tinnitus.
What about a sudden onset of hearing loss? That sounds scary.
Sudden sensorineural hearing loss, SSNHL, is defined as a rapid loss of hearing, usually occurring within a 3-day period of at least 30 decibels dB across 3 consecutive audiometric frequencies. This is considered an audiologic emergency.
Well, emergency. Why?
Because prompt treatment can sometimes reverse it, and you need to rule out underlying causes quickly. When a patient presents with SSNHL, the history and examination focus on identifying any potential underlying cause. Possibilities include viral infection, vascular events, autoimmune conditions, trauma, autotoxic drug exposure, or potentially a tumor.
So investigation is needed. Can't just assume it's nothing.
Definitely not. An MRI scan is typically required to rule out a tumor on the auditory nerve, specifically an acoustic neuroma, vestibular schwannoma, as about 1% of these tumors can present with sudden hearing loss. Routine blood tests are often low yield unless the history suggests a specific systemic cause like an autoimmune condition. However, in the majority of cases, estimated around 90%, no identifiable cause is found, and it's classified as idiopathic SSNHL.
Idiopathic meaning we don't know the cause. How is idiopathic SSNHL treated?
The recommended treatment is prompt administration of high-dose systemic corticosteroids, like prednisone, to reduce inflammation, often initiated within days of onset. Intratympanic steroid injections, injecting steroids directly into the middle ear space through the eardrum, allowing higher concentrations to reach the inner ear, may be used as an initial treatment, especially if systemic steroids are contraindicated, or as a salvage therapy if oral steroids are unsuccessful or only partially effective after about 2 weeks.
Does it work?
The prognosis for recovery varies, but early treatment is associated with better outcomes. Some people recover fully, some partially, some not at all.
Okay. Let's look at trauma affecting the inner ear. Noise exposure is a major factor here, right? Loud sounds.
Noise is a leading preventable cause of SNHL and tinnitus. Damage occurs to the delicate hair cells within the cochlea. This can result from a single, very loud sound exposure, acoustic trauma, like a gunshot or explosion, or from prolonged exposure to excessive noise levels over time, such as in certain occupations, or from loud recreational activities like concerts, or using power tools without protection.
And it causes a specific pattern of loss.
Yes, the characteristic pattern of noise-induced hearing loss on an audiogram is a notch or dip, typically most pronounced between 3 and 6 kilohertz. The source shows this specific frequency range effective. It's often accompanied by tinnitus. This is why regulations exist in many countries, including the UK, requiring employers to implement measures to protect workers from hazardous noise levels.
Head injuries can also affect the inner ear, even though the temporal bone is so hard. A skull fracture involving the ear.
Severe head trauma can indeed cause fractures of the temporal bone. These fractures can involve the otic capsule, the bony shell protecting the inner ear. Traditionally, temporal bone fractures were categorized as longitudinal, running lengthwise along the petrous bone, more common, 80%, or transverse, running across the petrous bone, less common, 20%. Although many severe fractures are actually mixed.
And they cause different problems.
Generally, yes. Longitudinal fractures often involve the external auditory canal and middle ear, potentially causing ossicular disruption and conductive hearing loss, and sometimes tear the dura, leading to CSF otorrhea leakage of brain fluid from the ear. Transverse fractures are more likely to directly involve the labyrinth, inner ear, and the facial nerve as they cross these structures. This results in a profound, usually permanent, sensorineural hearing loss and severe vertigo initially, though the brain gradually compensates for the balance loss over time, often with facial nerve paralysis.
And certain medications can damage the inner ear, ototoxicity.
Yes, a range of drugs are known to be ototoxic, meaning they can damage the inner ear structures, leading to SNHL and/or balance problems. Our source lists several important examples. Certain antibiotics, particularly the aminoglycosides like gentamicin, topramycin, amikacin, vancomycin, and erythromycin at high doses. Loop diuretics like furosemide, especially with rapid 5e administration. Chemotherapy agents such as cisplatin and carboplatin. High doses of salicylates like aspirin and quinine. Risk factors like pre-existing kidney problems affecting drug clearance, or concurrent use of multiple ototoxic drugs can increase the risk.
What about antibiotic eardrops? Are they risky?
While some topical antibiotic eardrops contain aminoglycosides, the source notes there's little evidence that short courses of topical treatment cause significant SNHL, presumably because not much gets absorbed into the inner ear.
Okay, let's shift focus fully to balance disorders now, specifically vertigo. What exactly is vertigo?
Vertigo is a very specific sensation. It's the hallucination of movement, typically a spinning or rotational sensation, either of oneself or the surroundings, when no such movement is actually occurring. It's important to distinguish it from other forms of dizziness, like lightheadedness or unsteadiness. Vertigo almost always indicates a problem in the vestibular system.
Either in the inner ear or the brain connections.
Exactly. Either in the inner ear labyrinth itself, peripheral vertigo, or in the vestibular pathways in the brainstem or cerebellum, central vertigo.
The most common cause of vertigo is benign paroxysmal positional vertigo, or BPPV. Break that down for us.
Okay. BPPV is indeed the most common cause of peripheral vertigo. It's benign because it's not serious or life-threatening, paroxysmal because it occurs in sudden, brief episodes, and positional because it's triggered by specific changes in head position.
What's actually happening in the ear?
The cause is mechanical. Those tiny calcium carbonate crystals we talked about, the otoliths, which are normally embedded in the gel in the utricle, become dislodged and migrate into one of the semicircular canals, most commonly the posterior canal.
The ear rocks get loose.
Basically, yes. When the head moves into a specific position, gravity causes these errant crystals to move within the fluid-filled canal, abnormally stimulating the hair cells there and triggering the sensation of intense spinning.
So the trigger is specific head movements, like rolling over in bed.
Yes, activities like turning over in bed, looking up at a high shelf, or tilting the head back can trigger it. The resulting vertigo is usually brief, lasting only seconds to maybe a minute, and is not associated with hearing loss, tinnitus, or other neurological symptoms. Diagnosis is typically made based on the characteristic history and confirmed by the Dix-Hallpike test.
The test where they move your head quickly.
That's the one. The clinician moves the patient's head into a provocative position and observes specific involuntary eye movements, nystagmus, that accompany the vertigo.
And treatment for BPPV. Does it go away?
BPPV can resolve spontaneously as the crystals may eventually dissolve or move out of the canal. However, recovery can be greatly sped up by particle repositioning maneuvers, such as the Epley maneuver.
The Epley maneuver.
Yeah, these are a series of specific head movements performed by a clinician that use gravity to guide the dislodged crystals out of the affected semicircular canal and back into the utricle, where they belong. Often very effective.
What about vestibular neuronitis? Sounds like nerve inflammation.
It is. Vestibular neuronitis is an inflammatory condition affecting the vestibular nerve, usually thought to follow a viral infection elsewhere in the body. It typically causes sudden onset, severe, persistent vertigo that can last for days, often accompanied by nausea and vomiting. Hearing is usually not affected.
And if hearing is affected?
If the inflammation also affects the cochlear nerve or structures, causing hearing loss alongside the vertigo, it's termed labyrinthitis.
How is it treated?
Treatment is primarily supported initially, using vestibular sedative medications like prochlorperazine, or meclizine to help manage the intense spinning in the first few days. However, early mobilization and vestibular rehabilitation exercises are crucial for promoting central compensation, helping the brain adapt to the abnormal input from the damaged vestibular system. Systemic steroids may also be considered to reduce inflammation.
Meniere's disease is another condition known for causing vertigo attacks. What's the story there?
Meniere's disease is a complex condition, and even its exact spelling and underlying cause are subjects of some debate in the medical community. The most widely accepted hypothesis for the pathology is endolymphatic hydrops, essentially a buildup of excess endolymphatic fluid pressure within the inner ear.
Too much fluid pressure.
That's the idea. This increased pressure is thought to damage the structures responsible for hearing and balance. Meniere's is characterized by a classic triad of symptoms that occur in episodic attacks: intermittent, spontaneous episodes of severe vertigo, fluctuating sensorineural hearing loss, typically initially affecting the lower frequencies, and tinnitus in the affected ear, often described as buzzing or roaring.
So vertigo, hearing loss, and tinnitus all coming and going.
Exactly. Patients may also feel a sensation of fullness or pressure in the affected ear before an attack.
And the vertigo attacks themselves, how long do they last?
Meniere's vertigo attacks are distinct from BPPV. They are spontaneous, not necessarily triggered by position change, severe, and typically last longer, from 30 minutes up to several hours, usually not more than 24 hours though. They're often accompanied by significant nausea, vomiting, and imbalance. The hearing loss and tinnitus usually worsen during an attack and may or may not return to baseline levels afterwards.
How is Meniere's diagnosed and managed?
Diagnosis is primarily clinical, based on the characteristic pattern of episodic vertigo, fluctuating hearing loss, and tinnitus. Investigations include pure tone audiometry, which typically shows the fluctuating low-frequency SNHL, and an MRI scan to rule out other causes of these symptoms, particularly an acoustic neuroma, which can sometimes mimic aspects of Meniere's.
And management.
Management is aimed at controlling the symptoms. Lifestyle and dietary changes, limiting salt, caffeine, alcohol, stress, are often recommended. Acute attacks may be treated with vestibular sedatives and antiemetics. For frequent or severe attacks, evidence-based medical options include diuretics to reduce fluid retention, or for more refractory cases, intratympanic injections of either dexamethasone, a steroid to reduce inflammation, or gentamicin.
Injecting gentamicin, an antibiotic.
Yes, it's used because it can selectively damage the vestibular hair cells to reduce vertigo attacks, but it carries a risk of worsening hearing loss, so it's usually reserved for severe cases where other treatments fail.
Vestibular migraine is often mentioned alongside Meniere's. Are they related? How are they different?
Vestibular migraine is increasingly recognized and is significantly more common than Meniere's disease, estimated to be about 5 times more prevalent. It causes episodic vertigo or dizziness that is linked to migraine mechanisms, even if a headache is not always present during the vertigo episode.
So migraine causing dizziness, not necessarily headache.
Right. Symptoms can include spontaneous or positional vertigo, motion sensitivity, nausea, and sensitivity to light and sound, but crucially, it is defined by the absence of the fluctuating hearing loss or tinnitus characteristic of Meniere's. Up to 40% of people who experience migraines may have associated vestibular symptoms.
How is vestibular migraine treated?
Management focuses on identifying and avoiding migraine triggers, which can include dietary factors like caffeine, chocolate, aged cheese, red wine, stress, lack of sleep, or hormonal changes. For frequent or severe vestibular migraine attacks, prophylactic treatment is often used, similar to headache migraines, including medications like beta blockers, calcium channel blockers, certain antidepressants, or anti-epileptic drugs.
Okay. Let's move on to facial paralysis, which we touched on earlier as being often encountered in conjunction with ear conditions. The facial nerve runs right through there.
The facial nerve, cranial nerve 7th, is a vital nerve controlling facial expression, taste sensation from the front of the tongue, and lacrimal tear and salivary gland function. Its path is long and complex.
Tell us about its journey.
It originates in the brainstem, enters the internal auditory meatus alongside the vestibulocochlear nerve, travels through a narrow bony canal within the temporal bone close to the middle ear and mastoid, exits the skull base at the stylomastoid foramen, and then branches within the parotid gland to supply the muscles of the face, a long and vulnerable path.
The most common cause of facial paralysis is Bell's palsy, right? Just comes on suddenly.
Indeed, Bell's palsy accounts for about 75% of cases of acute, isolated facial paralysis. It's diagnosed by excluding other causes. The most likely cause is thought to be inflammation and swelling of the facial nerve within its tight bony canal in the temporal bone, often triggered by viral infection, with herpes simplex virus being the most suspected culprit. It typically presents as sudden onset weakness or paralysis of one side of the face.
Treatment for balls.
For acute facial paralysis, strongly suspected to be Bell's palsy, prompt treatment with high-dose oral corticosteroids, within 72 hours of onset if possible, is recommended to reduce nerve swelling and improve the chances of full recovery. Crucial management also involves diligent eye protection.
Eye protection, why?
Because the patient cannot blink properly on the affected side, the cornea is at risk of drying out and getting damaged. So, using artificial tears frequently and taping the eye shut at night is really important.
But you mentioned earlier that it's essential to look for other causes, too. Not all facial palsy is Bell's.
Absolutely. While Bell's palsy is the most common, any facial paralysis warrants a thorough otoneurological examination to rule out other potential underlying causes. The facial nerve can be affected by pathology at multiple sites along its path.
Such as?
In the cerebellopontine angle, where it exits the brainstem, often by acoustic neuromas or meningiomas.
Okay.
Within the internal auditory meatus, within the temporal bone, by temporal bone fractures, middle ear infections like AOM or cholesteatoma or tumors, at the skull base, or within the parotid gland, by trauma or parotid tumors. An MRI scan is an essential investigation if the history or examination suggests any cause other than typical Bell's palsy, or if there's suspicion of a tumor.
And Ramsay-Hunt syndrome is a specific viral cause of facial paralysis related to shingles.
Yes, Ramsay-Hunt syndrome is caused by reactivation of the varicella zoster virus, the same virus that causes chickenpox and shingles, in the geniculate ganglion, a cluster of nerve cells in the facial nerve pathway. It's characterized by a triad of symptoms. Facial paralysis, often accompanied by severe ear pain, otalgia, and a vesicular rash, tiny blisters, occurring in specific areas.
Where does the rash appear?
Typically on the tympanic membrane, in the ear canal, on the pinna, or sometimes in the mouth. The source shows these vesicles. The virus can also affect the nearby vestibulocochlear nerve, CN8, leading to associated vertigo and sensorineural hearing loss. Treatment involves prompt administration of antiviral medication, like acyclovir, in addition to steroids.
Finally, let's touch on tumors affecting the inner ear or nearby structures. Acoustic neuromas.
Tumors originating within or near the inner ear are relatively uncommon, but must be considered in patients presenting with symptoms suggestive of inner ear or auditory nerve dysfunction, particularly if symptoms are unilateral. The most frequent such tumor is the acoustic neuroma, which is more accurately called a vestibular schwannoma.
Vestibular schwannoma, where does it come from?
It's a benign tumor that arises from the Schwann cells covering the vestibular division of the 8th cranial nerve, CN8, usually within the internal auditory meatus. Meningiomas, arising from the protective membrane surrounding the brain, can also occur in this area.
How do acoustic neuromas typically present? What are the first signs?
Vestibular schwannomas usually grow slowly, although their growth rate can be unpredictable. As they expand, they compress the nerves within the internal auditory meatus, leading to the classic early symptoms. Unilateral sensorineural hearing loss, often gradual but can be sudden, and unilateral tinnitus.
So one-sided hearing loss or ringing?
Yes. As the tumor grows larger, it can extend out of the meatus into the cerebellopontine angle, that space between the cerebellum and the pons in the brainstem. Here, it can compress other cranial nerves, like the facial nerve, causing weakness, or trigeminal nerve, causing facial numbness, and eventually compress the brainstem itself, leading to more widespread neurological symptoms or signs of raised intracranial pressure.
So unilateral hearing loss or tinnitus is a red flag. Needs checking out.
Absolutely. It is mandatory to investigate any patient with persistent unilateral sensorineural hearing loss or unilateral tinnitus with an MRI scan to rule out an acoustic neuroma. This is a critical diagnostic step. Don't ignore those symptoms.
And how are acoustic neuromas managed, if one is found?
Management depends on several factors: the tumor size, its growth rate, the patient's age, overall health, and symptoms. For small, slow-growing tumors, generally less than 2 centimeters, in asymptomatic patients or older individuals, a period of observation with serial MRI scans, watch, wait, and rescan, is often appropriate, as many grow very slowly or not at all.
And if it needs treatment?
Stereotactic radiotherapy, a highly focused form of radiation, can be used to control tumor growth in selected cases. For larger tumors, typically over 2 centimeters, or those causing significant symptoms, neurological deficits, or brainstem compression, surgical removal is often necessary. This requires specialized skull-based surgical approaches like the translabyrinthine, retrolabyrinthine, or middle fossa approaches, chosen based on the tumor size, location, and whether there is any usable hearing to preserve. The summary box on inner ear tumors and conditions provides key points here.
We've certainly done a thorough exploration of the ear, from its developmental origins to complex conditions affecting hearing and balance. It truly highlights the intricate beauty and potential fragility of this system.
It really does. The complexity and the interconnectedness are striking.
Yeah. Okay, now let's move forward to the other half of our deep dive. The nose and sinuses, the crucial airway gatekeepers.
Right. The nose is our primary interface with the air we breathe. It filters, warms, and humidifies inhaled air, and is also responsible for our sense of smell. The paranasal sinuses are air-filled extensions within the skull bones connected to the nasal cavity.
What do the sinuses actually do?
They play roles in humidifying air, resonance of the voice, and potentially reducing the weight of the skull. Let's start with the anatomy of the nose itself. Our source material shows the external supporting framework made of bone, nasal bones, parts of maxilla, and cartilage, upper lateral, lower lateral, and septal cartilages.
And the septum is the internal divider, the wall down the middle.
Yes, the nasal septum divides the nasal cavity into two halves. Its composition is partly cartilaginous and partly bony. The source shows this clearly. The anterior part is the flexible quadrilateral cartilage. Posteriorly, the bony septum is formed by the perpendicular plate of the ethmoid bone, superiorly, and the vomer bone, inferiorly.
And the lateral walls have those shelf-like structures, turbinates.
Those are the turbinates, the superior, middle, and inferior turbinates. You can see them in the diagrams. They are bony projections covered by thick, highly vascularized mucosa.
What's their purpose?
Their curve, shape, and arrangement create turbulent airflow patterns within the nose, which increases contact time between the air and the nasal mucosa. This extensive surface area and rich blood supply are essential for their primary functions: warming and humidifying incoming air to protect the lungs, and trapping inhaled particles via mucus.
The paranasal sinuses are connected to the nasal cavity, but their drainage pathways are complex, I understand.
They are. The paranasal sinuses are paired cavities, the frontal sinuses in the forehead bone, maxillary sinuses in the cheekbones, sphenoid sinuses deep behind the nasal cavity, and the ethmoid sinuses, a complex network of air cells between the eyes divided into anterior and posterior groups. Their drainage openings, or ostia, lead into specific areas of the nasal cavity called the meduses, which are located beneath the turbinates. This drainage system is crucial for health.
And different sinuses drain into different meduses. It's not all one big drain.
Correct. This is key to understanding the spread of infection and why certain areas get blocked. The anterior group of sinuses, the frontal sinuses, the maxillary sinuses, and the anterior ethmoid cells all drain into the middle meatus, the space beneath the middle turbinate. This area, particularly the osteomedial complex, is a critical bottleneck.
Okay. And the posterior ones?
The posterior ethmoid cells and the sphenoid sinuses drain more posteriorly into the superior meatus and the sphenoethmoidal recess, respectively. The diagrams in the source illustrate these drainage points. Obstruction of these narrow drainage pathways, often due to mucosal swelling, is the primary event leading to sinusitis.
Let's talk about the blood supply. As nosebleeds are such a common problem, it must be pretty rich.
The nasal cavity has an incredibly rich arterial supply, drawing from branches of both the external and internal carotid arteries.
Both major neck arteries supply the nose.
Yes. The external carotid system contributes via the maxillary artery, whose terminal branch, the sphenophylogene artery, is the major blood supply to the posterior nasal cavity. Branches of the greater palatinate artery also supply the anterior septum. The internal carotid system contributes via the anterior and posterior ethmoidal arteries, which branch off the ophthalmic artery from the internal carotid and supply the upper and anterior parts of the nasal cavity and ethmoid sinuses. The source shows these key arteries.
And where do these vessels meet up? Is there a hotspot?
Several of these arteries and anastomos connect to form a dense vascular network on the anterior part of the nasal septum. This area is called Kieselbach's plexus, or Little's area.
Little's area, that's where most nosebleeds come from.
Exactly. This is the most common site for nosebleeds, especially in children and younger adults. It's vulnerable to dryness, minor trauma like nose picking or forceful blowing, and upper respiratory infections.
What about venous drainage? The veins taking blood away. Any clinical significance there?
The venous drainage of the nasal cavity is via plexuses that connect to veins, including the ophthalmic, facial, pterygoid, and pharyngeal veins. Clinically, the most significant connection is the drainage via the ophthalmic vein, which communicates directly with the cavernous sinus.
Cavernous sinus, that sounds important.
It is. It's a large venous structure in the skull base near the pituitary gland and several cranial nerves. This connection provides a potential, though thankfully rare, pathway for severe infections from the nose or sinuses to spread intracranially.
So, a bad sinus infection could theoretically lead to a brain infection?
It's possible, potentially leading to serious complications like cavernous sinus thrombosis or meningitis.
How is the nose and sinus area examined? Can you see much just looking up someone's nose?
Initial internal inspection of the nasal cavity is often done using a simple nasal speculum, like a Thudicum speculum. This allows visualization of the nasal vestibule, the entrance, the anterior nasal septum, and the anterior portion of the inferior turbinate. But it's limited.
So, how do you see deeper?
To see deeper structures, the middle meatus, that critical drainage area for most sinuses, and the posterior nasal cavity, a more detailed examination using rigid or flexible endoscopes is necessary. Our source shows this endoscopic examination. These endoscopes are connected to a light source, camera, and monitor, providing magnified, illuminated views of the nasal passages and allowing visualization of polyps, sources of bleeding, or pus draining from the sinus ostia.
For imaging the sinuses, what's the role of different types of scans? Are X-rays useful?
Plain radiographs, X-rays of the sinuses, are now considered to have limited value and are rarely used for routine assessment. Computed tomography, CT, is the superior imaging modality for evaluating the paranasal sinuses.
CT is the go-to then.
Pretty much. It provides excellent detail of the bony anatomy and is invaluable for identifying sinus pathology like opacification, fullness, or mucosal thickening. Our source shows examples of opacified sinuses on CT compared to normal air-filled ones. CT is absolutely essential for surgical planning, especially for functional endoscopic sinus surgery, FESS.
FESS, we'll get to that. Why is CT so key for planning?
CP scans are reviewed in multiple planes, axial, coronal, sagittal, to assess the extent of disease, evaluate the anatomy of the sinus drainage pathways, and identify critical surgical landmarks and potential risk areas. Things like the level and symmetry of the cruciform plate.
The bit separating nose from brain.
Exactly. Part of the anterior skull base, right above the ethmoid sinuses. Also the thickness and integrity of the lamina papyracea, the paper-thin bone forming the inner wall of the orbit, adjacent to the ethmoid sinuses, and the location of major arteries, like the anterior ethmoid artery, which is a bleeding risk during ethmoid surgery.
You need that map. And MRI, does it have a role for sinuses?
Magnetic resonance imaging, MRI, is less suitable for visualizing the bony anatomy of the sinuses, but it excels at imaging soft tissues. It's valuable for assessing the extent of inflammatory disease, differentiating cysts from polyps or tumors, and is crucial for evaluating potential intracranial or orbital extension of disease or assessing tumors of the sinuses or skull base. So, good for soft tissue, less good for the bony details needed for standard sinus surgery planning.
Okay, let's discuss trauma to the nose and sinuses. Fractured nasal bones are probably the most common facial fracture, right? A broken nose.
They are very common, usually resulting from direct blunt force to the nose. The source shows a typical nasal fracture. The fracture can involve the nasal bones themselves and sometimes extend upwards into the lacrimal bone.
Is that dangerous?
Well, while seemingly minor, it's important to be aware that a fracture extending upwards could tear the anterior ethmoidal artery, located near the top of the ethmoid labyrinth. This can cause severe hemorrhage, and the bleeding might be delayed for several hours or days as swelling initially tamponades or compresses the torn vessel.
So a nosebleed might start later, and more severe trauma can affect the sinuses themselves.
Yes, high-impact trauma to the frontal area can fracture the frontal and ethmoid sinuses. Fractures involving the roof of the ethmoid or frontal sinuses can extend into the anterior cranial fossa, the floor of the front part of the skull, putting the brain and its coverings, the dura, at risk of injury.
And the big worry there is?
The major concern with these fractures is the potential for tearing the dura, which can lead to leakage of cerebrospinal fluid, CSF, and provides a direct pathway for bacteria from the contaminated sinonasal cavity to enter the cranial cavity, posing a significant risk of meningitis or brain abscess.
So CSF leakage from the nose, CSF rhinorrhea, is a very serious sign, like brain fluid dripping out.
Absolutely. CSF rhinorrhea, clear fluid dripping from the nose, is a definitive sign of a dural tear and an anterior skull base fracture. You can confirm it by collecting a sample of the fluid and testing for beta-2-transferrin, a protein found almost exclusively in CSF.
How do you find the leak?
High-resolution CT scans can help pinpoint the exact location of the bony defect in the skull base. Many small CSF leaks will heal spontaneously with conservative measures like bed rest and keeping the head elevated. But persistent leaks require surgical repair to prevent life-threatening ascending infection, typically performed endoscopically through the nose.
How are simple fractured nasal bones managed? The common broken nose.
Fractured nasal bones are usually accompanied by significant swelling and bruising, which makes it difficult to assess the precise alignment of the bones immediately after the injury. It's generally best to review the patient after 4 to 5 days once the swelling has reduced.
Can you straighten them?
If there's a significant visible deformity or nasal airway obstruction, the bones can often be manipulated back into a better position under local or general anesthesia. This manipulation needs to be done relatively soon after the injury, ideally within 3 weeks, while the bony fragments are still mobile.
And if it's missed or doesn't work?
If a good cosmetic or functional result isn't achieved with manipulation, or if the injury is assessed later than 3 weeks, a formal septorhinoplasty surgery to reshape the nose and possibly the septum can be performed, but usually not for at least 6 months to allow tissues to stabilize.
What if the injury primarily affects the nasal septum, the middle wall?
A blunt injury of moderate force, especially from the side, can cause the septal cartilage to buckle or be displaced laterally. Unlike the nasal bones, cartilage doesn't heal well with simple manipulation. If this septal deviation causes significant nasal airway obstruction, it requires a surgical procedure called septoplasty to straighten the septum and restore airflow.
How is that different from older techniques?
This contrasts with an SMR, submucous resection, an older technique where deformed cartilage was often simply excised. Modern septoplasty aims to preserve as much cartilage as possible while repositioning or reshaping it.
And a critical complication of nasal trauma, particularly involving the septum, is a septal hematoma. What's that?
This is bleeding into the space between the septal cartilage and the mucoperichondrium, the membrane covering it. It presents as a swelling of the septum, causing nasal obstruction. If this hematoma is not promptly incised and drained,
What happened?
the pressure of the blood clot can cut off the blood supply from the mucoperichondrium to the septal cartilage. The cartilage is then deprived of nutrients and dies, necrosis. This can lead to infection and abscess formation and ultimately collapse of the nasal bridge due to loss of septal support, resulting in a saddle deformity.
That sounds like it needs urgent attention. Can't wait on that one.
It absolutely does.
Yeah.
A septal hematoma is a surgical emergency requiring urgent incision and drainage of the blood clot, followed by placing a small drain and packing the nose to prevent reaccumulation and hold the mucoperichondrium back against the cartilage. Broad-spectrum antibiotics are also necessary to prevent secondary infection and abscess formation. The summary box on nasal trauma in our source emphasizes these key points, including the risk of CSF leak and the need for urgent drainage of septal hematoma.
So, the septum's structural integrity is vital. Let's talk more about problems with the nasal septum itself, like deviations.
Septal deviations are very common, either developing naturally as the face grows or resulting from trauma. They are often easily visible on anterior rhinoscopy. The source shows a significant deviation. If a deviation is causing significant nasal airway obstruction, particularly on one side, surgical correction is performed via septoplasty.
And the goal is?
As mentioned, the goal of septoplasty is to correct anatomical abnormalities, which might involve reshaping the cartilage, correcting a twisted bony septum, or removing a spur from the maxillary crest. The source illustrates areas often addressed. The aim is to restore a clear and open airway.
And what are the potential downsides or complications of septal surgery? What can go wrong?
Like any surgery, there are potential complications. The most common unique complication is a septal perforation, a hole through the septum, separating the two nasal cavities. Excessive removal of cartilage, particularly in the older SMR technique, can weaken the septal support and lead to collapse of the nasal dorsum, causing a saddle nose deformity or drooping of the nasal tip.
What are the symptoms if someone develops a septal perforation? How would they know?
Symptoms of a septal perforation vary depending on size and location. They can include a sensation of nasal blockage due to turbulent airflow, even if the airway is technically open, chronic nasal crusting and difficulty clearing mucus, recurrent bleeding, and sometimes a whistling sound when breathing, especially with forceful inspiration.
What causes septal perforations besides surgery?
The causes are diverse, as listed in the summary box in our source. The most common are trauma, especially iatrogenic injury during nasal surgery, and chronic irritation from nose picking. Untreated septal hematoma is another cause, as we discussed. Certain chronic infections like syphilis or tuberculosis, though rare in many places, can erode the septum. Systemic conditions like vasculitis, particularly granulomatosis with polyangiitis, formerly Wegener's, are important causes.
GPA again.
Yes. Also, certain tumors and exposure to industrial toxins, like chrome salt, or recreational drugs, like cocaine, which causes vasoconstriction and tissue death. Sometimes no clear cause is identified, and it's called idiopathic.
You mentioned granulomatosis with polyangiitis, GPA. What's happening there in the nose?
This is a serious systemic autoimmune disorder characterized by inflammation of small and medium-sized blood vessels. It commonly affects the upper and lower respiratory tracts and the kidneys. In the nose, it causes inflammation and formation of granulomas within the mucosa, which actively destroy the septal cartilage and bone. This leads to perforations and often the collapse of the nasal bridge, saddle deformity. Diagnosis is often supported by laboratory findings like elevated ESR, kidney dysfunction, and the presence of CA antibodies.
Can septal perforations be fixed? Can you close the hole?
Small perforations sometimes close on their own, but larger ones seldom heal spontaneously. Surgical attempts to close perforations using various grafts like cartilage or fascia or local mucosal flaps have varying success rates depending on the size and cause of the perforation. It can be tricky.
Any non-surgical options?
For patients bothered by symptoms but for whom surgery isn't successful or desired, a non-surgical option is to use a custom-fitted celastic biflanged prosthesis, commonly known as a septal button. The source shows pictures of this. This flexible silicone device is inserted to occlude the hole, normalizing airflow and reducing crusting and whistling. In some cases, for persistent whistling or bleeding from the specific edge, surgically enlarging a perforation slightly and folding the mucosa around the edges can sometimes stabilize it and reduce symptoms.
Okay. Let's move to the very common problem of epistaxis nosebleeds. Everyone gets them sometimes.
Epistaxis is extremely common, affecting a large percentage of the population at some point. The causes are numerous and can be local problems within the nose or systemic conditions affecting the whole body. Our source has a comprehensive table listing them.
Where do most nosebleeds originate? We mentioned Little's area earlier.
The vast majority of nosebleeds, especially in children and young adults, come from Kisselbach's plexus in Little's area on the anterior part of the nasal septum. That diagram showed the plexus clearly. This area is vulnerable to dryness, minor trauma, like nose picking or forceful blowing, and upper respiratory infections. Easily irritated.
What about older adults? Are their nosebleeds different?
In older adults, nosebleeds are more likely to originate from vessels deeper and further back in the nasal cavity, often from branches of the sphenopalatine artery. These posterior bleeds tend to be more severe and are often associated with underlying systemic factors like hypertension or the use of anticoagulant medications like warfarin or newer ones like apixaban.
Are there specific systemic conditions or rarer causes that lead to severe nosebleeds, ones to really worry about?
Yes, hereditary hemorrhagic telangiectasia, HHT, also known as Ostel-Weber-Rundu disease, is a genetic disorder that causes abnormal, fragile blood vessels, telangiectasias, throughout the body, including the nasal mucosa. The source shows these fragile vessels. Patients with HHT often suffer from frequent, severe, and sometimes difficult to control nosebleeds from these thin-walled vessels. A less common but clinically important cause, especially in adolescent boys, is juvenile angiofibroma.
Juvenile angiofibroma, what is that?
This is a rare, benign, but locally aggressive and highly vascular tumor that arises in the nasopharynx and can extend into the nasal cavity and sinuses. It characteristically presents with recurrent, often profuse, and potentially life-threatening epistaxis in this specific demographic, teenage boys primarily.
And how is juvenile angiofibroma diagnosed and managed? You can't just ignore that.
Diagnosis relies on cross-sectional imaging, particularly contrast-enhanced CT or MRI, which show the tumor's location and vascularity. A classic, though not always present sign on imaging, is the anterior bowing or indentation of the posterior wall of the maxillary sinus, known as the Holman-Miller sign. It is absolutely critical that a suspected juvenile angiofibroma is not biopsied in a clinic setting.
Why not?
Because of the extreme risk of uncontrollable hemorrhage. These things are incredibly vascular. Management involves a multidisciplinary approach. Preoperative embolization of the feeding arteries by interventional radiologists is often performed 24-48 hours before surgery to reduce blood loss. The source shows embolization coils used for this. Surgical excision is the definitive treatment, typically performed endoscopically or via an open approach depending on the size and extension, often utilizing image guidance systems for precision. Needs an experienced surgeon.
Let's go back to the general management of epistaxis. What's the step-by-step approach for a typical nosebleed?
For anterior nosebleeds, simple first aid measures like pinching the soft part of the nose firmly and leaning forward are often effective. Don't tilt your head back.
Right. Lean forward. What if that doesn't work?
If that doesn't work, a clinician can often identify the bleeding point in Little's area and control it with chemical cautery using silver nitrate, often after applying a topical vasoconstrictor anesthetic spray. For more posterior bleeds, identifying the bleeding point requires nasal endoscopy. Topical vasoconstrictors are applied, and the bleeding site is then cauterized using electrocautery if visible.
And if you can't see the spot or cautery doesn't work, packing.
If direct cautery isn't possible or effective, nasal packing is used to apply pressure to the bleeding vessels. Anterior nasal packing involves inserting material into the nasal cavity, such as Vaseline gauze, non-absorbable sponges like Maricel, or inflatable balloons designed for anterior epistaxis.
What about really bad bleeds from the back?
For more severe or posterior bleeding, postnasal packing is required. This involves placing a pack in the nasopharynx behind the soft palate, which is uncomfortable and usually requires sedation or general anesthesia. Various materials can be used, including Foley catheters or inflatable epistaxis balloons. The source shows a double balloon catheter, which has a balloon inflated in the nasopharynx and another in the nasal cavity.
What if packing isn't enough or the bleeding is very severe? Surgical options.
For persistent or severe bleeding refractory to packing, surgical intervention is indicated. Endoscopic ligation of the sphenopalatine artery is a highly effective procedure, approaching the artery in the posterior nasal cavity endoscopically. In rare, life-threatening cases where other measures fail, surgical ligation of other feeding vessels like the anterior and posterior ethmoidal arteries or even the external carotid artery may be necessary. Interventional radiology can also perform embolization of these vessels.
And you have to check for underlying causes too.
Absolutely. It's also crucial to identify and manage any underlying systemic factors contributing to the bleeding, such as clotting disorders or anticoagulant therapy. Platelet transfusions or reversal of anticoagulation may be needed in severe cases.
And specific management for HHT nosebleeds. Those fragile vessels sound tricky.
HHT nosebleeds are challenging due to the widespread fragile vessels. Traumatic methods like packing can worsen the problem. Management includes regular nasal saline irrigation and emollients. Medical options include high-dose estrogen therapy to induce squamous metaplasia and make the mucosa less fragile. Newer targeted therapies like bevacizumab, which inhibits blood vessel growth, and antifibrinolytic agents like tranexamic acid.
Any surgical options for HHT?
Surgical options range from endoscopic laser or electrocautery ablation of telangiectasias to more extensive procedures like septodermoplasty, replacing the septal mucosa with skin grafts. Or, in extreme refractory cases, surgical closure of the nostrils, Young's procedure. The summary box on epistaxis in our source provides a good overview of the management principles.
That's a lot to consider for nosebleeds. Okay, let's move to rhinosinusitis, the inflammation of the nose and sinuses. Very common, right?
Rhinosinusitis is one of the most common conditions affecting adults.
Yeah.
It's defined as inflammation of the nasal and paranasal sinus mucosa, diagnosed based on a combination of symptoms and objective findings.
What are the key symptoms?
Key symptoms include nasal congestion or blockage and nasal discharge, which can be clear, white, yellow, or green, along with facial pain or pressure and/or reduction or loss of sense of smell, hyposmenosmia. Diagnosis is supported by findings on nasal endoscopy, mucosal swelling, lupus, or CT scan, mucosal thickening, opacification.
How is it classified? Acute versus chronic?
It's classified by duration. Acute rhinosinusitis, ARS, lasts less than 12 weeks, and chronic rhinosinusitis, CRS, lasts for 12 weeks or longer. Newer classification systems categorize it further based on inflammation type and presence of polyps, but this duration-based split is fundamental.
Let's focus on acute rhinosinusitis first. The sudden onset sinus infection.
ARS is most commonly caused by a bacterial superinfection following a viral upper respiratory tract infection, the common cold. The viral infection causes mucosal swelling and impairs mucociliary clearance.
That mucus clearing mechanism.
Right. It gets impaired, obstructing the sinus drainage pathways. Bacteria then proliferates in the stagnant secretions. Common bacterial pathogens include Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis. Acute maxillary sinusitis can also specifically result from infection spreading from the roots of upper teeth, dental sepsis, often involving anaerobic bacteria.
What are the symptoms of ARS? How does it feel?
Typical symptoms include purulent nasal discharge, thick and often colored, facial pain or pressure over the affected sinus, forehead for frontal, cheek for maxillary, between eyes for ethmoid, and nasal obstruction. With maxillary sinusitis, irritation of the superior alveolar nerve, which runs close to the sinus floor, can cause referred pain perceived as upper toothache.
Ouch. What would you see on endoscopy?
On nasal endoscopy, the mucosa will appear inflamed and swollen, and you may see mucopurulent secretions draining from the sinus ostia, particularly in the middle meatus. If dental sepsis is the cause, the discharge may have a foul odor or taste.
Then imaging for ARCT again.
While plain films used to be used to show fluid levels, they are now largely replaced by CT, which provides much better detail. CT scanning is valuable for confirming the diagnosis of ARS by showing sinus opacification or significant mucosal thickening. It's also essential if complications are suspected or if surgery is being considered for refractory cases. The source shows examples of both plain film and CT findings.
How is ARS treated? Is it always antibiotics?
Management of ARS depends on severity. Many cases resolve with symptomatic treatment alone, such as analgesics and nasal saline irrigation. Antibiotics are prescribed for presumed bacterial infection, especially if symptoms are severe or persistent beyond 7-10 days. Topical nasal treatments are important adjuncts. Topical nasal decongestant sprays, used for short periods, 3 to 5 days, can help reduce swelling and improve drainage. Topical nasal corticosteroids reduce inflammation, and regular nasal saline irrigation helps clear mucus and debris. Surgical intervention, such as endoscopic sinus surgery, FESS, is generally reserved for cases that are unresponsive to optimal medical therapy or when complications develop. Historically, antral lavage, washing out the maxillary sinus, was sometimes performed, but this is now rare with the advent of endoscopic approaches.
And unfortunately, ARS can lead to serious complications spreading beyond the sinuses.
It can. Although less common now with effective antibiotic therapy, complications of ARS can be severe, involving the orbit, eye socket, or spreading intracranially. Infection can spread via direct erosion through bone or through small connecting veins, diploic veins.
What kind of intracranial complications?
Intracranial complications include epidural, subdural, or cerebral abscesses, meningitis, or encephalitis. Cavernous sinus thrombosis, that rare but life-threatening complication we mentioned, occurs when a blood clot forms in the cavernous sinus due to infection spreading from the sinuses. It presents with severe symptoms like bilateral ptosis, drooping eyelids, proptosis, bulging eyes, intense pain behind the eyes, ophthalmoplegia, inability to move the eyes normally due to cranial nerve involvement, papilledema, swelling of the optic nerve head, and high fevers. A real emergency.
Orbital complications affecting the eye socket are more common than intracranial ones.
Yes, orbital complications are more frequent, particularly arising from ethmoid sinusitis due to the thin lamina papyracea separating the ethmoid sinuses from the orbit. The source shows periorbital swelling from this. It also provides the Chandler classification, which grades orbital complications.
Grading the severity.
Exactly. From preceptal cellulitis, infection in front of the orbital septum, grade 1, to orbital cellulitis, infection behind the septum 2, superioscale abscess, pus between the bone and the membrane covering it, 3, orbital access, pus within the eye socket tissues, 4, and finally, cavernous sinus thrombosis.
What are the warning signs for orbital involvement?
Any sign of orbital involvement, swelling around the eye, proptosis, restricted eye movements, reduced vision, necessitates urgent ophthalmology review and investigation. CT with contrast is crucial, and prompt intravenous antibiotics covering aerobic and anaerobic bacteria. Abscesses, grades 3 and 4, usually require surgical drainage, which can often be done endoscopically. The source shows a CT scan of a superiostele access.
And infection of the bone itself.
Yeah.
Osteomyelitis.
Another potential complication is osteomyelitis, infection of the bone. This is particularly a risk with frontal sinusitis, where infection can spread to the frontal bone. If the anterior wall of the frontal sinus breaks down, it can lead to a fluctuant swelling and mass on the forehead known historically as Pott's-Povey tumor. The source shows a CT indicating this possibility. The summary box on ARS complications is vital here.
Okay. Now let's look at chronic rhinosinusitis, CRS, the persistent form, lasts longer than 12 weeks.
CRS is a very common and often challenging condition, affecting about 11% of adults. Its cause is multifactorial. It's not usually a simple persistent bacterial infection, but rather a chronic inflammatory process, often involving impaired mucociliary clearance, disruption of the mucosal barrier, and often microbial colonization or dysbiosis.
What factors contribute?
Factors contributing to CRS include anatomical issues, like a deviated septum or concha bullosa, an air cell within the middle turbinate, allergies, asthma, immune deficiencies, ciliary dysfunction, conditions where the tiny hairs that clear mucus don't work properly, and fungal elements in the mucus triggering inflammation. It's traditionally broadly classified into CRS with nasal polyps, CRS-WMPs, and CRS without nasal polyps, CRS-SMPs. Although more detailed endotype-based classifications looking at the specific type of inflammation are now being used for targeted treatment.
Let's specifically address nasal polyps, a key feature of one type of CRS. What are they exactly?
Nasal polyps are benign, non-cancerous, edematous, swollen with fluid outgrowths of the sinonasal mucosa. The source shows what typical polyps look like. Histologically, they are characterized by a loose, swollen stroma, heavily infiltrated with inflammatory cells, particularly eosinophils in many cases. Their exact origin is not fully understood, but they are thought to represent a manifestation of chronic inflammation.
Are there different types of polyps?
Inflammatory polyps are the most common type and usually occur bilaterally, typically originating from the sinus mucosa within the middle meatus and extending into the nasal cavity. A less common type is the antrochoanal polyp.
Antrochoanal.
Yeah, usually a single large polyp that originates in the maxillary sinus, the antrum, grows into the nasal cavity and can extend backward through the choana, the posterior nasal opening, into the nasopharynx. The source shows a diagram of this.
What are the typical symptoms of CRS with nasal polyps? How does it feel?
The main symptoms of CRS with nasal polyps are significant nasal obstruction, a watery nasal discharge, postnasal drip, and importantly, a reduced or absent sense of smell, aposmia or anosmia. Facial pain is typically not a prominent feature of inflammatory polyps, which helps distinguish them from other causes of CRS.
How do they look on examination?
On examination, endoscopy is usually required, polyps appear as pale, grayish, semi-transparent, glistening masses that look somewhat like peeled grapes. A key characteristic is that they are typically mobile and insensitive to touch when probed gently, unlike hypertrophied turbinates, which are more firm and sensitive.
Are there any specific considerations for polyps in certain populations, like kids or unilateral cases?
Yes. While inflammatory polyps are usually bilateral, a unilateral polyp in an adult should always raise suspicion for malignancy, and histological examination after removal is essential to rule out a tumor. Nasal polyps are also uncommon in young children. If seen, it's important to consider and rule out other potential causes like cystic fibrosis. Polyps occur in about 10% of CF patients, or rarely a meningocele or encephalocele, a herniation of brain coverings or brain tissue into the nose, which requires high-resolution CT of the skull base to exclude. The summary box on nasal polyps is a useful reference here.
How is chronic rhinosinusitis, particularly with polyps, managed? What are the options?
Management is often a combination of medical and surgical approaches, guided by the extent of disease seen on endoscopy and CT. Medical treatment is the first line. Systemic corticosteroids, like a short course of oral prednisone, can dramatically reduce polyp size and improve symptoms, but the effect is usually temporary, and polyps tend to recur.
So steroids help, but aren't a long-term fix. What is?
Topical nasal corticosteroid sprays or drops are the mainstay of long-term medical management to reduce inflammation and slow polyp regrowth, along with regular high-volume nasal saline irrigation, which helps clear mucus and inflammatory mediators. For severe CRSWNPs unresponsive to standard therapy, newer biological treatments are becoming available.
Biologicals, like for autoimmune diseases.
Exactly. Monoclonal antibodies targeting specific inflammatory pathways, like those involving eosinophils or IgE, are becoming available and can be very effective for severe CRSWNPs. For CRSSNPs without polyps, a long course of low-dose macrolide antibiotics can be helpful in selected patients, believed to act via anti-inflammatory mechanisms rather than purely antibacterial effects.
When is surgery indicated for CRS? When medical treatment isn't enough.
Surgical treatment is considered when symptoms are severe or persist despite optimal medical therapy. This involves endoscopic nasal polypectomy to remove polyps and functional endoscopic sinus surgery, SESS.
What's the goal of SESS?
SESS aims to surgically enlarge the natural drainage pathways of the sinuses to improve ventilation and allow better penetration of topical medications and irrigation, and to remove irreversibly diseased mucosa. The surgery is performed endoscopically through the nostrils, minimizing external incisions, and is guided by a detailed review of the preoperative CT scan. The CT serves as a critical roadmap of the anatomy and potential risks.
Are special tools used?
Surgical tools like the powered nasal microdebrider are often used in FESSS. The source shows one. This device has a rotating blade inside a sheath that shaves tissue away and a suction port to immediately remove it, allowing for efficient and controlled tissue removal, particularly of polyps and hypertrophied mucosa.
And what are the potential risks of sinus surgery? It sounds like delicate territory.
FESS is generally safe in experienced hands, but because of the close proximity of the sinuses to vital structures like the brain, eyes, and major blood vessels, there are potential, albeit uncommon, serious complications. These include cerebrospinal fluid, CSF leak if the skull base is breached, particularly the cribriform plate, and orbital complications such as damage to the lamina papyracea leading to postoperative bleeding behind the eye, orbital hematoma, which can compress the optic nerve and threaten vision, or damage to the eye muscles causing double vision. Wow, so checking that CT beforehand is critical. This highlights again the absolutely critical importance of reviewing the preoperative CT scan meticulously to understand the patient's specific anatomy, identify crucial landmarks like the level of the skull base and the anterior ethmoid artery, and assess the integrity of the lamina papyracea before beginning surgery.
Image guidance systems are also used during FDS sometimes, right? Like GPS for surgery.
Yes, surgical image guidance systems are increasingly used, particularly in complex FES cases, revision surgery, or when operating near the skull base or orbit. These systems register the patient's anatomy from the preoperative CT scan and use tracking technology to show the surgeon's instrument position relative to the scanned anatomy in real time on a monitor. It enhances safety and precision during dissection in complex anatomical areas. The source showed an example of image guidance being used for an angiofibroma, but the principle applies here too.
Finally, let's touch on tumors of the nose and sinuses. Are they common?
Tumors in the nasal cavity and paranasal sinuses, both benign and malignant, are less common than inflammatory conditions, but they must always be considered in the differential diagnosis, especially when symptoms are unilateral and persistent.
What symptoms should raise suspicion?
Typical presenting symptoms that should raise suspicion for a sinonasal tumor include persistent unilateral nasal obstruction, persistent unilateral nasal discharge, which may be clear, purulent, or blood-stained, recurrent or severe epistaxis, facial swelling or asymmetry, pain, or symptoms related to pressure on or invasion of surrounding structures like the eye, proptosis, double vision, or teeth.
What are some common benign tumors, ones that aren't cancer?
Simple papillomas, which are viral-associated growths, can occur in the nasal vestibule and require excision for histological confirmation, as they can sometimes resemble carcinomas. Osteomas are benign bone tumors, most commonly found in the frontal or ethmoid sinuses. They're often discovered incidentally on CT scans. The source shows an osteoma. They usually only require treatment if they cause symptoms like pain, obstruction of a sinus drainage pathway leading to infection, or if they grow significantly. They can often be removed endoscopically. A particularly important type is the inverted papilloma, also called transitional cell papilloma.
Inverted papilloma. Why is that one important?
These arise from the sinonasal epithelium and are characterized by the epithelium growing inwards into the underlying stroma. They are benign but have several significant characteristics: a high rate of recurrence after excision, a tendency to originate from the lateral nasal wall and extend into the sinuses, and importantly, a potential for malignant transformation into squamous cell carcinoma, SCC, in a significant percentage of cases, around 5–15% depending on the series.
So it can turn cancerous.
It can. On CT, they may show associated bone thickening or sclerosis. The source shows this finding. Due to the recurrence risk and potential for malignancy, complete surgical resection, usually performed endoscopically, is required.
And malignant tumors, actual cancers.
Malignant tumors of the nose and sinuses are relatively rare. The most common types are squamous cell carcinoma, SCC, adenoid cystic carcinoma, and adenocarcinoma. SCC is the most frequent. The source shows an SCC on the septum. Adenocarcinomas have a known association with occupational exposure to hardwood dust, such as in furniture manufacturing. Adenoid cystic carcinomas arise from the minor salivary glands scattered throughout the sinonasal lining. They are slow-growing, but have a tendency to invade nerves.
What signs suggest that a tumor might be malignant and invading surrounding structures? Red flags.
Signs suggestive of malignant invasion of neighboring structures, listed in a summary box and often visible on MRI, include symptoms related to orbital involvement, diplopia double vision, proptosis bulging eye, vision change, erosion into the palate or upper jaw leading to loose teeth, or an oroantral fistula, an opening between the mouth and maxillary sinus. The source shows this from a maxillary cancer. Trismus, difficulty opening the mouth due to pterygoid muscle involvement, cranial nerve palsies, or palpable enlarged lymph nodes in the neck. MRI is great at showing this invasion, as seen in one of the figures.
How are these managed? Sounds complex.
Management of sinonasal malignancies is complex due to their proximity to critical structures. They are best managed in a multidisciplinary team setting involving ENT surgeons, maxillofacial surgeons, radiation oncologists, and medical oncologists. Surgical expertise is critical, often requiring complex resections via endoscopic or open, e.g. craniofacial, approaches depending on the location and extent of the tumor. The source notes that almost half of these tumors arise from the lateral nasal wall and about a third from the maxillary antrum. Treatment typically involves aggressive surgical excision, often combined with postoperative radiation therapy, and sometimes chemotherapy, offering the best chance for cure. Thinking about sinonasal tumors, it really reinforces the importance of investigating persistent unilateral symptoms in the nose or sinuses, especially in adults. While most such symptoms are from benign causes like CRS, they can occasionally be the first warning signs of malignancy, and early detection significantly impacts prognosis.
Wow, we've truly covered a tremendous amount of ground in this deep dive. We started with the intricate mechanics of the ear, from the tiny hair cells to the complex balance system, explored common issues like infections, hearing loss, and vertigo, and then moved forward to the nose and sinuses, detailing their anatomy, common conditions like sinusitis and nosebleeds, and the signs of rarer but serious issues like tumors.
It's quite remarkable how interconnected these systems are, and how a problem in one area can lead to symptoms or complications in another, whether it's eustachian tube dysfunction affecting the middle ear or sinus infections potentially spreading towards the orbit or brain.
Yeah.
Understanding these anatomical relationships is really key to appreciating the body's warning signs.
Hopefully, this deep dive, drawing from such a detailed source, has given you that truly well informed perspective, that aha moment that moves you beyond the superficial understanding to mastering the essentials of this fascinating and vital region, just like the professionals navigate it.
It really is about gaining that appreciation for the complexity and recognizing when seemingly simple symptoms might be hinting at something that needs further attention,
Yeah.
you know.
Absolutely. And thinking about all we've discussed today, from the possibility of an earache being a sign of a throat cancer to persistent unilateral nasal symptoms being a red flag for a tumor, isn't it fascinating how localized issues can sometimes reflect a much larger, more complex picture?
Mm, yeah.
It truly highlights the body's intricate way of signaling distress and the importance of paying attention to those signals. Something to perhaps ponder as you go about your day and maybe experience one of these systems at work: hearing, breathing, balancing.
Indeed. A lot going on behind the scenes.
Until next time.